also be going into how dissociation can be triggered during an examination, as well as what you can do to try and prevent that from happening and what you'll want to do if it occurs. And finally, we'll get into how to differentiate dissociation from dissociative identity disorder. Our goal is for you to leave this session knowing exactly how to screen for dissociative identity disorder so that you can do it with confidence. Because here's the thing about DID.
It's so poorly recognized. That's why I'm so glad you're doing this segment here on dissociation. That there's a lot of psychologists who still say, "Oh, it's a fictitious disorder. It's made up by people."
So we'll get into that toward the end. But right now, let's get a better sense of what we mean when we talk about dissociation.
Dissociation means disassociation. In most of our lives, our experiences are associated to each other. But some of the earliest observations when people started to learn about trauma, the central point was that when you get traumatized, the experience doesn't get associated with the rest of your life. So the earliest definition of trauma is that trauma is a dissociative response, where the experience is so overwhelming that it is stored in a different part of your mind, different part of your being, and doesn't become part of your larger whole.
With that in mind, let's get into trauma's effect on the brain and body and why that can lead to dissociation. To do this, we'll look at how trauma can fragment your patient's sense of self.
We all have different parts of ourselves, right? We all have different self states. For example, today, I'm in my professional state, whereas when I'm playing with my niece and we're crazy at a party, I'm in my play state. Or, when I'm treating a patient, then I'm in my psychiatry state. Or when I'm with my husband, I'm in my wife's state. And so we all have these different states. But if we're good at regulating our emotions, we can have awareness of all of these states together, and we can regulate all these states while being co-conscious of them at the same time. So one overall state of consciousness works. However, if we're severely traumatized and we have intense emotions and intense memories that are horrific and haunting us, just being aware of all these different states in one all the time would be unbearable, right? And so states start to separate.
Now, here's another way to think about how this can often play out when trauma occurs. In essence, your patient self splits into two or more parts. One part holds the trauma, and the other part tries to get on with daily life. But the trouble is,
the more severe and the more prolonged the trauma, there can start to become more splits. So there can be numerous parts. There can be daily life parts that go to the job, daily life parts that engage in sexuality, that have take care of the children, that have social relationships, and they can not be fully communicating, although there might be some overlap in their communication.
You just heard from Dr. Ruth Lanius and Dr. Pat Ogden. They've laid out two difficult challenges of working with dissociation. First, when trauma fragments your client's sense of self or their self states, that can happen along a continuum. On the one end, the patient is aware of their different states. That's what Ruth referred to as co-consciousness, where she described being conscious of her professional state, her wife's state, and her play state, all at the same time. But on the other end of the continuum, if the memory of the trauma gets too intense, the patient's sense of self can completely fragment, and they can lose that co-consciousness.
This is when we sometimes don't remember what we've done, where we lose large amounts of time, minutes to hours to sometimes days, and that would be consistent with a dissociative identity disorder.
So keep that in mind for later in the session when we'll go more in depth into dissociative identity disorder. But right now, let's look at a second challenge in working with dissociation, and that is your patient's dissociative parts can operate independently and they don't integrate. And that can be profoundly debilitating for your patient. Now, we'll look at specific strategies for helping your patient integrate their different parts in just a few minutes. But first, it can be very important to understand how and why parts function the way they do. And there's one critical concept that can help us. I'm talking about the structural dissociation model. This is a model developed by Kathy Steele along with her colleagues Dr. Anno Vanderhart and Dr. Ellert Nijenhuis. You see, trauma can create a tug of war between two internal systems, the attachment system and the defense system. And that's what the structural dissociation model helps to explain. So let's get into it.
Structural dissociation poses that dissociation occurs along these little fault lines, like you have in earthquakes, these little fault lines between motivational systems that we all have. We talk a lot about attachment, and we talk a lot about defense, as in fight, flight, freeze, faint. Those are two motivational systems that we have. If we think about disorganized attachment in children who are being abused, the basic fault line there is between the need to attach, which has its own neural networks, its own physiology, its own predictions and perceptions and goals and behaviors, and the motivational systems of defense, fight, flight, freeze, faint, etc. Those are mostly biologically incompatible to have activated at the same time because physiology is different. But also the goals are different, the motivations are different, the actions are different. And so a child with disorganized attachment is trying to do the impossible by both attaching to, approaching, and avoiding or defending against the same person. And so this very natural crack, if we want to call it that, or division in the sense of self of the child, and in all of the perceptions and predictions and behaviors and somatic experiences, begin to become more separate because they're so difficult to pull together. So we can begin to see on a sort of psychobiological level why children might begin to develop these divisions.
So you might think of these structurally dissociated parts as compartmentalized trauma responses within your patient. And these dissociated parts are often in conflict with one another. Here's another way you might think about this. On the one hand, a child wants to be close to the parent or caregiver. But on the other hand, when that child senses the parent or caregiver is threatening or downright harmful, being close to them becomes frightening and often dangerous for the child. The result? A nervous system that's out of whack, dysregulated in either hyper or hypoarousal. And when your patient's different defense parts are working in opposition to each other, it can feel highly distressing, not only for your patient, but also for their loved ones, as well as for you as the practitioner. So that's an overview of the concept of structural dissociation. But how can you recognize the signs of structural dissociation? For Dr. Janina Fisher, there are 3 explicit red flags that can help us hone in on it.
In my mind, the first thing to look for are paradoxes and contradictions. For example, the client reports struggling with shame, but at times we notice that client also is very superior, talks down about, my boss is so stupid. My partner is emotionally unintelligent, and right, there's a contradiction. Right, the client is very afraid. I'm thinking of a former client of mine who had such fears of
of leaving her house. She was so agoraphobic, except in the middle of the night, she would be so in such a panic that she would go running at 1 or 2 in the morning. We're talking about a 32-year-old young woman um, going jogging at 1 or 2 in the morning. So paradoxes. Um, the we see this all the time. One of my favorite signs, red flags, is the client alternately devalues and idealizes the therapist. It's a it's a paradox. It's a contradiction, right? If I'm such a wonderful therapist, why are you attacking me? And if you're attacking me, if I'm so terrible, why are you still with me? Those are two different parts. The attached part, or cry for help part, idealizes the therapist. The fight part is hypervigilant and mistrustful, and wants to keep the therapist at bay.
Now, Janina just touched on attached cry for help. As I know you know, in addition to fight or flight, there's the freeze response. And last week, we focused the entire session on that response because while people know that it exists, it's gotten a lot less detailed coverage than fight and flight. But according to the latest thinking among trauma experts, in addition to fight, flight, freeze, we now recognize several other modes of defense against real or perceived threat. Attached cry for help is one of those additional modes of defense that experts now recognize. In addition to that, there's also collapse, submit, and please and appease. We'll be talking about all of these new strategies of defense next week in our session. We'll get into how to recognize them and how to work with each of them. But right now, I want to keep going with these red flags of structural dissociation. So, as you just heard, the first red flag is paradox or contradiction that can sometimes signal the inner struggle between two parts. But this struggle between dissociated parts can be expressed in other ways too, which brings us to the second red flag. Janina calls it terminal ambivalence.
Clients who cannot make a decision about big things or little things. They can't go forward. They take a step forward, and then somehow they can't take the next step. Or they take a step forward, and then they quote unquote self sabotage. And because I believe that the mind and body are designed for adaptation, I don't believe in secondary gain and self sabotage. So I had to think, what could cause what looks like self sabotage other than some strange unconscious process? And I realized, the sabotage may come from a part that doesn't trust taking a step forward.
Now, in addition to staying alert for paradoxes or contradictions, and also for stuckness and ambivalence, there are some somatic indicators of dissociation that you want to keep an eye out for. And this is where you might come across the third and one of the biggest red flags.
One of the biggest red flags is clients who report that either they've had no benefit from any medication that they've tried, and they've tried them all, or clients who report paradoxical side effects. For example, an SSRI that is normally activating puts the client to sleep. So that's a paradoxical side effect.
Now, those are three indicators of dissociation that come from your patient. But another indicator might come from your own internal experience. We know from polyvagal theory that we share a connection with others at the level of the nervous system. We can either feel co-regulated with another nervous system. That's the good stuff of feeling safe in our body with another person. Or we can feel dysregulated around another nervous system, unsafe, vigilant, or numbed out. That's why tracking our own nervous system can alert us to the potential of fragmentation in our patient.
When I start to feel confused, disoriented, inadequate, kind of turned upside down, and I found this to be true whether the therapist is right out of graduate school or has been in practice for many years, that feeling of being completely confused, incompetent, and at sea occurs with these highly fragmented clients.
So you can pick up on your patient's dissociated parts by tracking your patient, but also by tracking your own inner experience. Now, so far, we've walked you through trauma's effect on the brain and body and how that can lead to dissociation. Then we introduced you to structural dissociation. We dug into the key signs and symptoms that can help you suss out whether your patient experiences dissociation. So now let's get into some specific strategies for working with dissociation. To start, what's the first thing you might do if you sense that you're working with a patient who dissociates?
I think the first thing that clinicians should do if they suspect that they have a dissociative client is take a deep breath. Try not to rush into starting to explore parts right away. I've seen too many clients who have been a bit overwhelmed by that. If you really think about dissociation, dissociation is about hiding from yourself. It's about not wanting to be that thing, that experience, that little girl, that memory. I don't want those things. And so to be confronted by that all of a sudden is often quite overwhelming for clients.
So, just like we talked about in last week's session, we see again how important it is to slow down and set a pace that your patient can manage. And real quick, I want to go deeper into something else that Kathy just said about how dissociation often involves patients hiding from themselves. You see, it can also involve patients erasing themselves. Here's how you might think about that.
So many times we are floating or going through the motions of living, but we have been taught to erase ourselves. We have been taught to not feel. We have been taught to neglect ourselves. So it's different if we're dealing with a natural disaster or a medical trauma. But when there is a perpetrator or an offender, the purpose of the act is really to erase, to minimize, to dehumanize, to dishonor.
So that's a tragic outcome of trauma, particularly interpersonal trauma. Interpersonal trauma often teaches people to become invisible, to erase themselves, as Dr. Tamer Bryant just put it. So when that happens, what can you do to foster healing?
As a part of the healing work, it is visibility instead of erasure, to help me to see myself, right? To honor myself, to be present with myself, to nourish myself. So, as we're helping people with recovery and facilitating that process, an important outcome for us to consider and to present to clients for determining if that is of value to them is this notion of integration and authentic acceptance of myself. And I like to call it coming home, the homecoming, coming home to myself.
We'll go further into how to help clients integrate, or as Dr. Bryant Davis just said, come home to yourself, a little later in the session. But right now, as you hear each of these strategies, I'll ask you again, just like I did last week, think of a few of your patients. Which of these strategies might help your patient reach a breakthrough? I want you to be keeping that in mind because all the training in the world won't make a difference if you don't apply it to your practice. So let's move on to the next strategy and let's look at what you want to do if your patient is experiencing the fragmentation of structural dissociation.
If we're talking about structural dissociation, it's about attention and awareness plus plus. It's about getting behavior under your control, getting your own thoughts, your own emotions, owning your own emotions, not having it belong to another part of you. And it is about getting these parts of self to come together to be more cooperative and coordinated. We might say coherent and cohesive. That's a much bigger project than just limited to the mind around attention and awareness.
In a session, you might think of this as working toward achieving the 4 C's. You're looking to bring the parts of your patient's self together so that these parts are more cooperative, coordinated, coherent, and cohesive. So now let's get into some strategies for integrating your patient's structurally dissociated parts. I'm going to give you 3 approaches. The first will be a somatic approach, the second, an experiential approach, and the third, a cognitive approach. So first, let's get into the somatic approach. Take a look at how you might work with your patient's dissociated parts by using their posture and movement.
I really track for how parts are represented through different movements and postures in the body, and then use the body to help integrate. So, for example, with one client, she had a collapsed posture like this. And there was another that was hopeless. It was a shutdown, hopeless state. And another part of her was assertive and wanted to move through the world and accomplish things. So if we're working with integration, we are at risk of overriding certain parts through our physical resources that we develop. So I asked her to go back and forth between that part that was assertive and the part of her that felt collapsed and shut down. And I said, let's see if we can bring them together through your posture. So she would explore back and forth until she could find the posture that included both these parts. And then that became her homework. Okay, for this week, why don't you just pay attention to a posture that doesn't override that collapsed part, but that includes that part.
Because posture and movement often hold important cues about your patient's different parts, it can be so helpful to know how to use the body as a way to bring those parts together and integrate them. Next, I want to show you how you might address your patient's dissociated parts from a more experiential angle.
I really want to stay in the experiential mode where people learn to meet themselves, meet the hated part of themselves, meet the unacceptable part of themselves, and really set up a dialogue with that hated, unacceptable, scared, humiliated part of themselves, and to have them tell them what it was like back then. To really help them to make the separation. Right now, feel your butt in the chair. I'm here. You feel scared of me? No, I don't feel scared of you. Now, let's go and let's visit that little kid who got molested. I have despised my whole life for being so weak and so whiny that she didn't take care of herself. That's not me as an adult, that's me as a child. To get blended, our job is to try to unblend these parts.
Now we're up to the cognitive approach. With this one, your goal is to help your patient investigate their thoughts. And beyond that, you're getting them to identify which parts of themselves those thoughts might belong to. Let me show you what this might look like in practice.
When you're working with dissociation, I think it's really helpful to identify thoughts as thoughts, not as the truth. So if a client says things like, it's all my fault, I'll say, okay, so that's a thought, isn't it? And I might even ask, what happens when you have that thought? So we're really putting a gap between um, their identification with that thought. And it's a way of helping them become mindful. Yes, it's a thought. It's not true. It's a thought I'm having. And I think that that is really, really helpful with all clients, but especially with highly dissociative clients. And that can kind of prevent dissociative patterns because you're catching them before the client has fully gone into the part that holds that thought. And then I might say, well, let's find out about the part of you that has that thought. So right away, then we're working with communication. There's the part that has the thought, and then there's the bigger part that can stay with me and learn about that part. And it's the same with terror. If the client goes, I'm so terrified. I say, okay, so there's a part of you that's terrified. Let's find out about that part of you. And again, we're working with the communication rather than having the client just identify with and go into that terror. And when a client can become curious about how they're organizing their experience internally through their thoughts, their emotions, their images, smells, tastes, and their movements and sensations, that is just so empowering. And you're getting underneath the content to what's really driving the content.
So far, we've talked about how to tell whether your patient is experiencing dissociation, and we've also shared strategies for how to work with your patient's dissociated parts. Right now, I want to give you some strategies that you can use to help your patients ground and return to the present if they dissociate in a session with you. So, first, how can you tell when that might be happening?
So I think, if attention starts to fade, if people start to look zoned out like this, often their eyes change, they're looking upward, you see, a lot of the white of the eye. Sometimes, you see quick eye movements and then things shift. And sometimes the breath becomes really shallow and people are much less responsive. Those are all things to watch for when people dissociate.
Now, that's 4 specific cues of dissociation that you want to zero in on: zoned out eye gaze, eye movement, a lack of responsiveness, and shallow breathing. So, once you detect that your patient is dissociating, you might ask,
Are you with me? And, there may be a delayed response, and people may say, yeah. And then I know they've sort of drifted off, right? And then I would ask, how much of you is here right now? And what I've learned is that people can always answer that question. And so they may say to me, 50% of me is here right now. And then I would say, and what do we need to do for you to feel safe for all of you to be here, or most of you to be here? And so this could be, standing up, change in posture, feeling more powerful, walking. I often find helps people to ground because often walking while being aware that now they're an adult and they can walk away from whatever that they may want to walk away from can be very grounding.
as adults, people can often walk away. And so you're trying to get your patient to come into the present, into their adult self that can make choices. This idea is the basis for an approach used extensively by somatic therapists, where you help your patient identify an action or physical gesture that they could not do as a child, but they can complete as an adult. But I need to note, there are certainly times when adults experience trauma that is inescapable as well. So again, when an adult comes to see you having experienced adult trauma, they may also need help completing the action that they were unable to execute at the time of trauma. And actually, just last week, In our first session, Dr. Pat Ogden shared a very practical 4-step process for helping your patient do this. Now, if you missed that session or you'd just like to see it again, you might consider registering for a gold package. With a gold package, you get the audio, the video, the transcript of every session in this program. Not only that, you'll also get several bonuses, plus the unique suite of learning tools that make using the ideas from each session as simple and as streamlined as possible. And all of that is yours to permanently keep. And one more thing, your purchase will support our mission to share this program with practitioners all around the world without regard for their ability to pay. You can purchase the gold package with the link right below, anytime during or after this broadcast. So let's move on to the next strategy. This is one you might use to help your patient ground and return to the present if they begin to space out in session.
If a client starts to space out, um, one of my favorite interventions is I say, "Oh, the spacey part is here. How interesting." And this idea that spaciness can be a part was something that just occurred to me spontaneously with a client a number of years ago who just kept going away. And and it was so effective because if you say to a client, "I notice you're spacing out," it triggers shame, right? And but if I say, "Oh, look, the spacey part is here. Wow, just in the nick of time. How lovely of the spacey part." It kind of brings the client back um, in a way that makes the client curious rather than ashamed.
Notice the skillful way that Janina brings a discussion of the dissociated parts into the work here. She uses curiosity to decrease shame, to increase the client's mindful awareness of the presence of the parts. Now, another way to decrease shame is by using psychoeducation.
If I've given clients psychoeducation about the window of tolerance, I can also just say, "Wow, it looks like your nervous system is getting pretty up there. Do you notice that too?" And it's very interesting. If I sort of blame it on the nervous system, again, clients don't feel shame. They say, "Oh yeah, 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 I am getting a little hyper," and I say, "Yeah, your nervous system idles high. Yeah, it really is sensitive." Um, and or I said, "Yes, your nervous system is really traumatized. We got to help it."
Now, Janina just brought up the window of tolerance. As I know you're aware, the window of tolerance was developed by Dr. Dan Siegel, and it can be a useful tool to help you and your patient track their overall level of arousal. Not only that, notice here how exacting Janina's language is and how carefully she explains what the nervous system is doing. This can help you talk to your patient about their dissociative symptoms, but without triggering shame. Now, another highly effective method for helping patients who may become dysregulated or who dissociate in sessions is working with the breath. Integrating the breath into your work might sound easy, but there's one way that it can backfire.
If the client's not breathing, I'll take a breath. One of the cardinal rules is we never ask a client to do something physical without doing it with them. Because otherwise, the client is going to be asked to do something and then get stared at, which is very, very triggering. So I might say, let's just pause for a moment and take a breath. This is a lot. We're doing a lot today. And I don't want you to get overwhelmed. So actually, let's both take another breath. And I might model a sigh, which is my favorite breathing technique. Say, yeah. Because when you sigh, the wonderful thing about the sigh is when you sigh, you're breathing out. And as soon as you finish sighing, there's a very relaxed in breath that's very easy, very fluid. It's almost, if you're not noticing, if you're not tracking your body, you don't even notice that you've sighed and then you've taken this spontaneous in breath. So it's a very, very easy way to help people regulate their breathing, which regulates the nervous system.
I appreciate Janina's example here. You see, you can introduce very powerful methods for calming the nervous system without needing to do a lot of explaining or instructing. We just saw Janina do it with the sigh. You also want to work in true collaboration with your patient. It's so much easier to help your patient regulate their nervous system if you're doing that breathing or sighing along with them. Now, there are also other ways to calm the nervous system using polyvagal based approaches. And if you're registered for a gold package, you'll be receiving a special bonus on several strategies featuring Dr. Stephen Porges. Now, before we move on, let's look at one more strategy that you might use to calm a dysregulated nervous system.
I love also to bring online positive imagery and containment imagery that really helps individuals to stay within that window of tolerance. So one image that I think is very helpful for clients when they become overwhelmed is imagining a chest and putting all the intrusive material that has come up into that chest, locking the chest and putting it away somewhere until they're ready to deal with that material more fully. So I think that's a really good way of using imagery.
Now, this strategy Dr. Ruth Lanius just shared as part of our Critical Insight session. That's just one of the 4 special learning tools that you'll get if you've registered for a gold package. In addition, you'll get a full set of learning tools with each of the 5 modules in this program. You see, we've designed them to help you turn the ideas and concepts from each module into practical applications that you can use immediately with your patients. So if you haven't yet registered for a gold package and you'd like to, you might do so at any time during or after this broadcast. Just use the link below. So by now, we've shared with you a roadmap for how to help a patient who dissociates in session. But what if you take a wrong turn somewhere along the way? Or what if your pacing is off? Or what if you miss that your patient is moving out of their window of tolerance? I want you to look now at several specific cues that can tell you this might be happening.
I might be clued into the fact that something is too early. For example, if a client has a very difficult time getting regrounded with me, if it's taking an inordinate amount of time, whatever we were just talking about was too big. If a therapist moves a little bit too quickly, is some people begin to get very hyper aroused, agitated, and they may start to engage in self harm right there in session because that's their way of regulating. They may be more prone to start drinking or using drugs, self harming outside a session too. It's a crucial skill for therapists to learn to tell when a patient is in their window of tolerance and when they're going out of it.
So once you sense your patient has gone out of their window of tolerance and you see them start to self harm, what are some ways that you might course correct?
If they start engaging in self harm in my office, when you're scratching yourself, you're showing me that that was too fast. And if we can work together to talk about you telling me in words, for example, usually the self harm begins often from a state of hyperarousal. And I might have missed it right there. I think I did. Let's work together so we both can see when you're starting to get flooded with too much emotion. Or it might be conflict. I want to tell you about this, but I think I'm going to get in very big trouble if I tell you about this.
Okay, let's keep moving because I want you to get an even broader sense of what can go wrong when you're working with dissociation. So let me walk you through 2 other mistakes that can lead to stalled treatment. We'll also give you ways that you might avoid making these mistakes with your patient. So first,
A common mistake that people make, that I made in the early days of being a therapist, was around empathy and empathic contact and resonance with the client. Like kind of that right brain empathic contact. Oh, this is so hard. You're in so much pain. Oh, I'm so sorry this happened. Which comes from a very compassionate place for all therapists, I think, and the place of wanting to help. What can happen with a highly dissociative client is that that can stimulate parts that are not ready to be integrated, especially parts with attachment needs. Most of our traumatized clients had attachment needs, like we all do, but theirs were not met. They were often abused, neglected, etc. So we have to be careful about stimulating those needs too quickly before the client has the integrated capacity to really tolerate the strong attachment related emotions.
so you see, there are times when your reflex to offer compassion and empathy can backfire. It can sometimes even cause more dissociation for your patient. But why is that? Well, for someone who's experienced sexual abuse as a child, proximity or closeness might have preceded the abuse. So a kind tone of voice or empathic expression might cue a memory of threat. This can be tricky not only for mental health practitioners, but also for physicians and nurses or physical therapists or occupational therapists, even for teachers, pastors, and parents. Because when you see someone in pain or distress, your first instinct is often to extend sympathy and understanding. So, when you notice that a compassionate approach isn't helping, how might you respond instead?
What I would do instead is I would be much more matter of fact. And I would track the response because I would want to keep the client relatively in that window or at the edge, not going over the edge. So if I track they're going over the edge, I get more matter of fact and more just, you know, just definitive, less emotional contact. I would I would track for those signs. The client starting to go too far over the edge, and I often will ask clients, how are you doing? Are you with me? And that's a way of also getting them to regulate. So sometimes I'll say something and I'll track them and their response, and I might say, that was a little too much, wasn't it? And they'll say, yeah. That track and contact and recover, I think, is essential.
So, notice there are nuances in how you might use your voice with patients. If you're tracking your patient's nervous system and you notice them going out of their window of tolerance as you're using an empathic tone of voice, you can switch to a more matter of fact way of speaking to help them downregulate. Now, remember at the top of this session, I let you know that there's one common oversight that can keep patients stuck and often saddled with a history of failed interventions. Let's get into exactly what that is.
The most common reason I find that a case has bogged down or gotten stuck, or the client has a history of many different treatments, none of which have worked, I would say probably 75% of the time, the answer is that this client is structurally dissociated, but no one has picked it up. We certainly recognize spacing out as dissociation, or the client going away. That's, I would say, most therapists recognize that as dissociation. But fragmentation or structural dissociation is most often diagnosed as personality disorder. I really feel as if we need a way to bring recognition of dissociation as a phenomenon, as a state, as in spacing out, but also as compartmentalization or fragmentation. So the fact that we underdiagnose structural dissociation and dissociative disorders means that we have a whole subgroup of traumatized clients who are not improving because we see them as personality disordered rather than as fragmented.
I want to underscore what Janina just said about the potentially tragic consequences of missing or overlooking structural dissociation. Because by recognizing a client's underlying fragmentation, you can avoid putting your clients in jeopardy of coming to a standstill, stagnating, or even deteriorating in therapy. So now that we've looked at a few ways that treatment can go off track, I want to pivot into what medical professionals need to know about recognizing and working with dissociation. If you're a physician or a nurse, perhaps the first thing to remember is that sometimes your patient's physical symptoms can be a stand in for emotional trauma. Let me show you what I mean.
Reason why people go to see a primary care doctor. There is nothing actually wrong. There's nothing physically wrong. So it is some kind of an emotional or trauma kind of thing. And physical symptoms can be a form of dissociation. So instead of feeling the emotion or the trauma, we have bodily symptoms. So you have all of these physical symptoms as a way to dissociate from the emotional experience.
That was Dr. Peter Levine. He's one of the world's leading experts on the treatment of trauma, and his point bears repeating. Complaints of physical pain can sometimes be dissociated emotional pain left over from trauma. So, what are some other considerations that practitioners in medical fields might need to be aware of, especially when it comes to patients who dissociate?
In a primary care setting, where people really aren't trained in dissociation, they can notice when a client's spacing out in the exam room. They can notice when a client is in that fight, flight, freeze kind of experience.
Now, according to Kathy Steele, some physicians, and particularly gynecologists, have had experiences where their patient was on the exam table and started to cry. Your patient might even begin to start talking like a child.
And so, what we might see there is that maybe this person is switching to a traumatized child state. And so, I think primary care providers can be given some simple instructions on what to do if they see that, which is to back off, help calm the client, don't touch the client, um, create a little distance from them, just saying, you're safe, I'm going to stand here and just talk to you, I'm not going to touch you, it's okay for you to sit up. So giving them instructions as to, helping them feel safe and not continuing to try to do what they're doing, like to give a vaginal exam. It should just immediately stop. The same with giving injections. Any medical procedures can be very triggering for clients because it's so reminiscent of being held down, not having control, being in pain that somebody else is giving. It's a big trigger situation. And I think caregivers can be given some pretty simple instructions for how to deal with that.
Kathy's example reminds us how important it is to always be observing your patient's responses and behaviors so that you can take corrective measures as soon as possible and avoid making a problem worse. Not only that, there's another step medical professionals might take in order to work skillfully with a person who dissociates.
So I think anybody working in the medical field who is working directly with patients should be asking general questions of How is your sleep? Do you have nightmares? If somebody has sleep disruption, to ask about that. If they're having problems with sleep, often trauma survivors have tremendous trouble with sleep, so they could find out about it there. And also just asking, have you experienced any traumatic event, anything that was terribly frightening to you in childhood or adulthood? And is that likely to have impact on how we work together? What would be the best way for us to work together so you feel in control? Just asking about that and being sensitive and giving them some room to tell you, well, let's just go slow about that, and could you have your nurse in here with me? That sort of thing helps a client get through the exam.
So these are all key steps to help you recognize and work with dissociation, especially if you're a physician, a dentist, a nurse, or a physical or occupational therapist. But let's go even a little further now, because it can also be critical to know how to differentiate between dissociative identity disorder and dissociation. So, first, here's an immediate red flag that your patient might have dissociative identity disorder.
What you look for is people who look very differently on different days, with very different presentations, whose voices change, whose appearance changes, who seem to go from being perfectly calm into being enraged or shut down or compliant or go into a fear state. And you see it in the same person who one moment is presented one way, the next moment in a different way, and who generally don't have much of a sense of how that shift has happened. There's very little capacity for self-observation that says, oh, when you asked me that question about my boss, I got so upset because my boss reminds me of my uncle who raped me. So I started to relive the state I was in when I was assaulted. No way somebody's going to say that until they have had 100 years of therapy.
So, again, you're assessing for dramatic changes in your patient's presentation that they're not aware of. But I'd like to also give you several specific questions that you can ask to help you screen for dissociative identity disorder.
The question I ask to check whether somebody may have a dissociative identity disorder are actually relatively simple. I start by asking, do you ever lose chunks of time? And if the person says, no, never happens to me, I think it's unlikely. However, if the person says to me, yeah, there's minutes, hours, sometimes days, and then I ask, and do you remember what happens when you lose time? And they say to me, no, I have no idea. Then the chance of having a dissociative identity disorder is higher. And then I follow it up with a question, for example, do you ever feel detached from your own body? And if they say yes, I get them to explain that. And then I would ask a follow-up question, does your body ever feel like it doesn't belong to you? And if they say yes, then again, it's much more likely that somebody has a dissociative identity disorder.
You might start out with some simple questions that can help you get a sense of your patient's connection to both time and their body. After that, you'll want to ask your patient some questions about voice hearing. But here's the thing. Broaching this particular question with your patient will require some delicacy.
I think you have to be very careful when you ask about voice hearing, because often people don't disclose it because they're afraid that they'll automatically be diagnosed with schizophrenia if they tell you. So I normalize it and I say to them, we're now finding out that in people with early life trauma and a lot of dissociative symptoms, voice hearing is very common. So I'm going to ask you about that, and just rest assured, if you are experiencing that, I don't think that you automatically are suffering from schizophrenia. And that's actually been very helpful in my assessment of dissociation. And people will disclose hearing voices much more readily. And then I ask about hearing voices, and if they say yes, I would ask about child voices because often people with schizophrenia don't have child voices. I would ask about onset of voices, and again, the earlier the onset of voices, the more likely it's a dissociative disorder, not schizophrenia. And I would ask, how many voices do you hear? And again, if it's more than 3 voices, it's more likely a dissociative early life trauma or dissociative disorder.
So, after observing responses and behaviors and asking the screening questions you just heard, after that, how do you arrive at a diagnosis for dissociative identity disorder?
You ask the client about 5 types of dissociation while you're observing yourself, watching for any signs of dissociation. So, depersonalization, derealization, identity alteration, identity confusion. To have full blown DID, you have all 5 of these types of dissociation together. The last one is dissociative amnesia. Dissociative amnesia is absences, chunks of time missing, for example, of current day that are just way too big to be normal forgetting. So you assess slowly, gradually to see if it's DID. I take that very slowly because it can be very frightening to a client. The whole time I'm still working on helping them learn to regulate their emotions, get grounded, and get safer. So a mistake is getting so curious about the disorder that you might jump into diagnosing it and bringing it up with the client too quickly. And that might cause them to follow apart with more dissociation and or self-harm. So you want to go slowly with that. Take it at the pace they can tolerate it safely.
So, notice again here the emphasis on going slowly. According to Dr. Bethany Brand, another challenge for practitioners is sometimes that a part of the patient blames and even is hostile to the practitioner. When this happens, here's what we need to remember.
First of all, therapists, don't take it personally when you're being criticized. Understand that that part of the mind is doing their very best to keep the patient safe. And based on their past history, they know that others can be harmful. And so they may have mostly the understanding that if you let down your guard with anybody, you're going to get creamed. You're going to get hurt. And so they may be trying the best to keep the person safe and not attaching to you because they have attachment fears. That's a crucial element. And the natural inclination for therapists is stay away from what you're scared of, just like for all of us, we stay away from what we're scared of. And that's a mistake with DID.
Now, the last challenge that we'll touch on here has to do with working with your patient's child parts.
Often therapists are drawn to child parts. Keep in mind that there is some protector part that has learned that if we attach, we get hurt. And so if a therapist starts to work with DID in childlike states, because they're sweet, they're adorable, they hurt, they need help, and they can elicit such caregiving from the therapist, and you can start to lose a sense this is an adult with a child state. Some therapists, out of the most compassion in their heart, start to work with them as if they are children and attend to that too much. And instead, what's more helpful is rather than going to that early, is get to know what the concerns are of the persecutory voices. What is the fear that as I'm talking to you all, to the whole client, about getting grounded, you're trying to interfere with that? You're trying to interrupt that. What is your concern about grounding? Why does that feel like it's not a good idea?
When a patient is fragmented, we need to keep in mind that these child parts are traumatized parts and not the adult that we're trying to form a relationship with. So now we've covered how to distinguish between dissociation and dissociative identity disorder, how to screen for dissociative identity disorder, and how to overcome some of the challenges of working with DID. Next, I'd like to give you the key strategies that are necessary for effective treatment of dissociative identity disorder.
The goals are going to be the same in many ways when you're working with DID as when you're working with complex trauma. There's got to be stabilization, improvement of safety, and developing of the relationship. And so for stabilization, you're stabilizing, you're helping them understand what their symptoms are, what emotions are, and how to regulate that. So they have to start learning about their bodies and how to tell when they're getting hyper aroused, hypo aroused. They need to learn, just like any client who does self harm, what are the triggers for self harm? What problem are they trying to fix through the self harm? And what are safer ways, recovery focused ways of dealing with that issue?
So, as I know you know, there are so many factors that can contribute to dissociation. That's why it's crucial to access the full context of your patient's life and experiences. And not only that, it's critical to know how to work with their dissociated parts. Now, next week, we'll be back with the next free session in the Advanced Master Program on the Treatment of Trauma, and we're going to go into how to work with 3 specific defensive adaptations to trauma. We'll cover attach, cry for help, collapse, submit, and please and appease. But for right now, please go to the comment board and share your biggest takeaway from today's session. Let us know how you're going to apply it to your work. You can find the link right below. You'll have a chance to see what other practitioners have to say about how they're using it with their patients as well. It might just spark some ideas for you. And I'll close again by saying, what you do is so important. I truly believe that when we help someone heal from trauma, you change the course of civilization. That's because it's not just that person's life that changes, but that healing can also have an impact on their spouse, their children, their friend, and their colleagues. And that can ripple out into the community, to their state, their country, and eventually to the world. Thanks for what you do, and thanks for watching.